Okay, great. So welcome everyone to this webinar. My name is Trygve Ordersen. I'm Executive Director for Infection Control here at the Norwegian Institute of Public Health and also Chair of the European Network of IANPHI. And the European Network is hosting and organizing this webinar series where this particular webinar is part, and that is organized together with Public Health Agency of Sweden and Anders Tegnell in particular, who is also on the panel. I thought before we start, I will just say some words, at least why I think this is an important topic and an important webinar. For me, it's really two big questions that we are about and might address today. One is really, how can we get the priorities among different preventive interventions right? I mean, there's a lot of preventive interventions, both at the population level and at the clinical level. And with limited resources, how can we really focus on the right one? Then there is this, in some sense, even bigger question. How can we get the balance between preventive interventions and other kind of interventions, curative and clinical treatment in particular? How can we get that balance right? And one of the reasons why it's so hard to at least get sufficient priority to prevention is the mix of quite stubborn, I should say, drivers that at least often push us towards other kind of interventions, including curative services. And some of those drivers, and I hope we will partly discuss today how we can better counteract or address those drivers, is the perceived urgency, which might be higher for curative services, that the beneficiaries of preventive services is also often unidentified, and the benefits, of course, is long into the future, although the cause might be very acute or occurring today. Is less tech and fancy. The evidence base is sometimes perceived as inferior to some of the clinical services. It's really multi-sectoral often. It requires collaboration across sectors. I think we will hear more about that in this webinar. We have less strong patient organization often, and then to the contrary, we have less often forceful industry pushing in the direction of actually prioritizing the intervention, and sometimes even very strong against certain preventive services, including, of course, regulation of certain harmful products. So that's just part of the backdrop, at least in my mind, why it's so important to discuss and be really conscious about this topic and how we can improve the prioritization of preventive interventions. And why now then? Why have this webinar now? It's many answers, but just to mention at least two in my mind. One is that there is really a dynamic kind of scene now with regard to both public health and intersectoral collaboration, partly driven by the pandemic and experiences from the pandemic. And then, of course, we're also in a time where the economics and questions about sustainability and resource scarcity is even greater, I should say, than in many years. So for at least both those two reasons, I think this webinar now is very pertinent. So that's why at least I'm very happy that we could have this webinar. We have 4 great panelists that will share their experiences and also offer, I think, some possible solutions that we can learn from each other. And at least my objective or our objective with this webinar, as for the other webinars, is really that we log off and have some new ideas for how we can help our public health institutes, so wherever we are located, to improve our public health work. The structure of this webinar will be quite simple. We will have 4 introductions by each of the panelists, and then we will have, I hope, ample time for discussion afterwards. And please have a very low threshold for either putting questions, comments in the chat, even while the panelists are speaking. And then if you would like to ask questions, just put it in the chat or raise your hand. Both is good and would be really important if we were to have a good discussion and learn from each other. And then finally, as it says here, be aware that the webinar is recorded. That's because we get so many requests from people that would like to watch this later. But keep that in mind. So without further intro, I will go straight to the first speaker of our great panel, and that is Annika Veimer, who's the director of the Estonian National Institute for Health Development. So over to you, Annika.
Yes, good afternoon, everyone, and good afternoon from Tallinn, Estonia. Like Trygve Ottosen introduced, this is National Institute for Health Development speaking, and I'm Annika Veimer. And thank you, IANPHI, and also Public Health Agency of Sweden for launching this thematic webinar series, where today is one of the first ones we call in Estonian the first sparrow. And I hope there are many more sparrows to follow. And this is an excellent way to share and learn from each other. So I will be, like the introduction went, that we would be discussing priorities, how to set priorities, how to distinguish prevention from dealing with the consequences. And when you add scarce resources into the formula, then things get quite tricky. So I will give you an example on how we have tackled lifting prevention in Estonia, based on the example of cross-sectoral prevention. So next slide, please. Next slide, please. Yes, thank you. So the concept of cross-sectoral prevention was created in 2020 in Estonia by experts from different ministries and agencies. Ministry of Social Affairs, which is responsible for also health, Ministry of Education and Science, Ministry of Justice, National Public Health Institute, Social Protection Agency, Police and Border Guard, private sector players, and also third sector. So there were many who started the concept. And the concept is based on analysis that was done already in 2016 that confirmed that prevention system in Estonia is lacking joint coordination, is lacking principles, and there is no really clear understanding who has what role in the system, who contributes what, and if the contribution is there after all. So the situation was such that there were gaps between science and practice. The efforts were fragmented between areas of responsibilities of different ministries. And as a result, there was no clear understanding of prevention interventions. Do they reach target groups? What resources exactly are lacking? And what is missing, where the gaps are? And the concept that was developed provides evidence-based guidance to decision-making and the resource allocation in prevention. So the concept is meant for mainly policymakers, decision makers, but it does have a wider use by offering guidance and inspiration also to everyone who is working in the prevention scene. Next slide, please. Prevention is more successful and effective when it is addressed in a similar way and with common objectives. So in 2021, the ministries that are responsible for different prevention programs met and decided that several of government level commissions should merge with the aim to create one cross-sectoral government level prevention council. The key players in the merger were Council for Child Protection, Council for Crime Prevention, and Commission for Drug Prevention. So based on the three, there was a merger, and there was a need for central coordination and direction, since behavior and crime prevention were fragmented between organizations, and more resources were always allocated to dealing with consequences rather than prevention. So the aim was to create a common understanding of prevention and agree contexts and principles of prevention efforts. So the main principles of the cross-sector prevention that were agreed upon were that it was decided jointly that main target group of prevention activities are children and youth, first of all. Then long-term cross-sectoral action plan was needed. It was made clear that it's needed, and it was decided that it will be created. Now it is in the making for 2023 to 26. It was also decided that evidence-based prevention activities will be preferred, especially those with already a proven track record of results, and also conditions will be created to study effectiveness of promising prevention efforts. And the main focus will be on increasing skills of workforce who is implementing the prevention interventions. Next slide, please. And prevention is more successful and effective when it is addressed in a similar way with common objectives. So the ministries that are responsible agreed on what the roles of actors are. So it was clear that there is a necessity for a central coordination body, that is the Prevention Council. It is formed of leaders from different ministries and state institutions. Then there is a cross-sector prevention task force, and with a task to organize planning and implementing and evaluating prevention interventions. And then to advise on what works and what doesn't and how to measure it is a Prevention Science Council, which supports evidence-based decision-making. Next slide, please. And like a normal work cycle, first there needs to be planning, then interventions, decision on interventions, what is needed, then educating and guiding the workforce, executing the actual prevention efforts, and then organizing also evaluation and assessment of the efforts, and then making sure that project-based funding is there for prevention. Next slide, please. Yes, next slide. And there is a definite role in objectives for the Prevention Science Council, and three things which require several tasks to be performed. First of all, there is a need to agree on terminology, and this is a task for Prevention Science Council. We need to agree on principles on how evidence of prevention intervention is evaluated, actually analyze the prevention that is currently being implemented in country, and develop also a registry which provides an overview and insight into current prevention and existing effectiveness, that what is there, and also listing the assessed prevention interventions which lack evidence base, so that there is clear understanding what can be used and what shouldn't be used. Also, the Science Council advises cross-sectoral government commission, Prevention Council on National Policy Development and Decision Making, and also gives advice how to match funding systems with evidence assessment, and especially stressing proven evidence. We also advise owners of prevention programs on how to increase quality of interventions, and agree on common points on directing prevention efforts. Last year, for example, to support this work, we organized EUSPR annual conference. EUSPR is the European Society for Prevention Research. Annual conference in Tallinn to offer broader understanding of the concept, and it was paired with our annual Estonian National Prevention Conference to involve a wider audience of professionals working in the field of prevention. So to conclude, it will be a continuous effort to ensure that we do spend the scarce resources on prevention with proven results, with evidence base. We do have a lot of work ahead of us, but we must acknowledge that over the last few years, we have taken a good step forward in organizing or thinking through how cross-sectoral prevention works, organizing ourselves on principles, that agreeing on common principles, and then moving forward on assessing what actually works in Estonia and making sure that we only use the resource of money, people, and effort on what works. Thank you.
Thank you very much, Annika. Very great start, and really about one of the both challenges and solutions, I believe, of prioritizing preventive interventions. The plan is to mostly save comments and questions, or not comments, but questions for later. But if there are any burning ones, at least we get we have one here, so maybe we should or two questions, Annika. So maybe we can take those before we move on. Let me see, I missed them. The first one is, what is the makeup of the Prevention Science Council, and why has a separate body for evaluating the evidence of prevention interventions? I mean, why do we have a separate one and don't integrate it into another one? And is it just because of its multi-sectoral nature? So basically 3 questions there.
Well, yes, like I explained in the presentation, that how it came to be the Prevention Council is that there are several stakeholders from 6 ministries representing different areas, and the council itself was a merger of 3 councils, just to make sure that we address prevention similar way or on similar agreed principles cross-board. This is why there is Prevention Council in the beginning. The Prevention Science Council is to develop the assessments and actually assess the prevention programs which are being executed right now. And we do that together with universities. The Prevention Science Council is led by the National Institute for Health Development, and there are members from all Estonian universities, especially those who are working on behavioral sciences. So we do assess the programs and develop the ways to assess the programs which are already being implemented in prevention, but also those who are being developed as we speak. And National Institute for Health Development is the research institute developing the prevention program. So we are building the assessment already into the programs that we develop. And yes, the answer is that it is multi-sectoral of nature, and we just want to make sure that everything's research evidence-based. So we build the evidence base and help to build evidence base into it.
Great. So thank you, Annika. I think that clarified it very well. We have one more question here. It's about overlapping areas of responsibility at the communal level. I mean, how do you deal with that? Multiple actors at that level, I guess, have responsibility for creating help promoting living circumstances that it suggests here. And who is then responsible for that in Estonia, and how is it funded?
Well, in Estonia has a beauty of being a small country, so we do not have too many layers of government. We do not have separate states. It's 1.3 million country. So the ministries agree on the funding, and then the funding is directly moved through either the National Institute for Health Development or the local municipal level to the target groups. So it is actually quite simple funding system. The thing is to make sure that we only fund prevention programs which are evidence-based, and this is why this prevention council was brought to life. And also to create ownership into that system, it has been decided that every year the management or organizing the prevention council rotates between the ministries. So this year the Ministry of Justice is taking the lead. Next year it moves to another ministry. So everyone feels like they are a stakeholder and are involved.
Oh, great. And let's take a last one, Annika, before we move on, if it's okay for you. It's about, I just want to have something more about the scope of Prevention Science Council and what will be the range of issues that will be addressed. So I guess what kind of interventions are we talking about?
Well, this is where I also mentioned during the very short presentation that yes, it can get overwhelming very soon, and that this is why early on, at least for a few years to come, it was decided that the main target groups will be children and youth. And since the three councils that were merged involved child protection, crime prevention, and drug prevention, then this is the main focus for the Prevention Council efforts.
Great. So thank you very much again. We have more time for questions after the panel, but let's turn over to Anders Tegnell and the Public Health Agency of Sweden, who was, and I mean, Anders was really the one initiating the idea for this webinar. So over to you, Anders.
Thanks a lot, and thanks both to you, Trygve, because I think you really voiced some of the really critical problems in prioritizing prevention, and also to Annika, because I think your description of the problems in prioritizing prevention, we can transfer them to Sweden word by word. So I think we're really dealing with many of the same issues, and hopefully we can find some common solutions also around this. So next slide, please. I think for often in public health, the context is very important, and just to sort of show you the context in Sweden, which is slightly more complicated than is in Estonia. I mean, we have the government, we have the different ministries. Here is justice and social health and social welfare, just examples. And then under each ministry, there is a huge amount of different agencies. And of course, this is one of the main problems of prioritizing and prevention and dealing with prevention activities, is that there is so many different actors involved. It's not only in the area of health, not even if you include social welfare, but also many other ministries are involved. And if we take the next slide, Sweden also has 3 levels of governance, each of them according to our laws, each of them paying their own taxes. So everything is paid out of 3 different big bags of money. And we have the municipal level, which runs social services, care for the elderly, and care for environmental health and many other areas. We have the regional level, which runs the healthcare system and the public health systems in general. And also the communal disease control, and a few other things, but mainly runs most of the hospitals in Sweden. And then we have the national authorities and the national level, where public health agency is one of, I think, more than 300 agencies in Sweden. And we coordinate a number of different areas within the area of public health and a few other things. And if we look at the next slide, you can see that even in Sweden, it's definitely not a big country. We have a division in 21 different regions, and the regions vary in size from 60,000 people up to almost 2 million people. So this is also one of the areas of creates problems when you try to coordinate it. And we have almost 300 municipalities, some of them very small with only a few thousand people. And they still have to run schools and long-term care facilities and many other things in those small populations. So these really creates a number of challenges for public health and priorities in public health. And so we have over time created a number of different things, as you had in Estonia, to try to deal with this. And if we look at the next slide, one of them was the creation of the Public Health Agency in Sweden, which was created a little bit more than 10 years ago now, which was a fusion of a number of different agencies. And really, one of the main reasons was really to try to get to better coordination in the area of public health, which was previously done just in the area of health, was done in 3 different agencies. And the agency now has a broad responsibility in the area of public health, data collection, surveillance, disease prevention, health promotions. And some of the areas that are really priorities these days are of course mental health, which we all know. NCDs is high on the agenda. Different kind of substance abuse is also very high on the agenda, as well as sexual reproductive rights. And there is also a number of other things in place that we try to put in place to somehow alleviate the problems with this very diverse and huge number of actors involved. If we look at the next slide. So priorities are taken at all of these different 3 levels, because each level is very independent, has their own economy, and has their own financing of the activities within their scope, even if there is different ways of distributing money between the different communities and between the different regions, and the state also to a certain extent finance things that are included in the other actors' mandate. But since a few years back, we have a national policy for public health, you can call it, with goals for public health and closing the gaps between different groups, because one of the main problems in public health these days is really that we have quite a big part of the population where the health improves gradually over time, not so fast anymore, but still improving. But we have a smaller group who really falls behind, and this is really the focus of this strategy. And to support that, the Public Health Agency a few years ago got a mission from the government to set up a support structure for that, and the different areas that were defined in this strategy. And that includes also to follow up what happens in these different areas and what kind of results we can see. As a further way to prioritize, apart from this structure where the priority for closing the gap is very clear, we also every year get specific missions from the government pointing to certain areas where we need to do more work, and we often also get extra money, and there is also extra money sent to both the communities and the regions through this. And mental health is one of the major areas where we really had a huge increase in activity from the national level over time. At the regional and community level, there is a common structure to try to somehow work together. And there is also nowadays, together with National Agency, a council for the knowledge-based steering. And that council has one of its main areas of interest that preventive work should be emphasized. So in a number of ways, we have tried to put in structures, so Sweden has tried to put in structures to still give priority to preventive services, even if it is very difficult. And if you look at the next slide, at the agency, we have worked with a structure that looks into one of the two questions that Trygve took up, and that is which preventive measures should we put in place. And we do this in 3 steps. We start with identifying possible areas that both needs prevention and where there are possible measures that could be used. And that's very much done through the data collection and data analysis we do at the agency. But of course, politically identified needs are also important in this. We get also signals from a number of other areas. And then priorities are setting according to public health policy, ethical dimensions, what the data tells us, and what legal possibilities we have in place. And then, of course, we have to look at effects, evidence quality, feasibility of the possible measures that we can look at. And then we divide the different measures into different levels, and this is then sent out and given to the regions and the communities as a basis for their work in prevention, so they can choose, hopefully, what are the best measures that we can put in place. And just finally, one more slide. Next slide, please. So, so the situation in Sweden, I think it's similar in very many countries, that public health and preventive measures really are complicated because there's so many actors involved, not just in the area of health, but also in almost all other ministries that are part in the preventive activities. And we tend to, as Trygve also said, end up very often, especially to regional level, in comparison between curative and preventive measures. And this is difficult because they are not always possible to compare them in any reasonable way. And that's one of the reasons why we really took the initiative to have this webinar, to see how can we get away from that comparison between curative and preventive measures. Because the curative measures, as several have said already, are often much stronger. They have stronger advocates. They're easily quicker to see that they have an effect and so on, while preventive measures takes a little bit more of patience to understand how important and good they are. So this is just to give a quick short background to where we are in Sweden in this area. Thank you.
Thank you very much, Anders. I think this speaks well, as you say, to problems and challenges that are common to many of us. Can I just, you say preliminary model, could you just say a bit more about where you are? Is this a model to be implemented quite soon or under development?
No, this is a model that's already in place, and we use it to some extent already. Because one question we often get, especially from the smaller communities, is what kind of measures should we really use? And I think this is really an area where we also, I think we could have a broader collaboration in trying to find good ways of really pointing to the really effective measures in public health, because that is not completely easy always to understand and to measure.
Oh, great. Thank you very much. And one thing I forgot to say in the beginning on the list of things that sometimes make it more complex for preventive, at least population-based preventive measures than the clinical measures is the need for contextualization. Sometimes harder to know exactly what intervention works in one municipality and versus another, as opposed to knowing what drug works in one population rather than another. Although we often underestimate also the last bit. So then we have some questions here. One Anders, do you do any kind of turn on investment modelization on prevention or health promotion interventions? So return on investment analysis.
We have done a few tries to do health economics on preventive measures in tobacco control, among other things. I know. So there's been some done. We are also building some models to try to measure the impact of preventive measures in, for example, diabetes. Taking the data from the Swedish population and trying to sort of understand what happens when we have different interventions in place. And I think that's quite interesting and something we would love to share with other countries, because I think it's an important area when it comes to convincing, especially the politicians, about how important prevention is in public health.
Great, thank you. And I think that's something many of us are looking into, how to strengthen the case for preventive, at least population-based preventive interventions by that kind of analysis that might also convince the Ministry of Finance more easily. Then we have another one, Anders. Mahid here say, I want to know more about the prioritization of the preventive indicators, which you have shown on the second last slide.
I think these are ones that we often use in other areas. I mean, they are very similar to what we use when we do priorities for vaccine programs, and also quite similar to the ones we use when we look at screening programs and so on. So I think that they are, in our mind, a fairly generic set of criteria you need to look at when you go into with interventions like this.
Great, thank you. So if it's okay, let's move on to the next panelist, and we can continue the discussion after the panel. Next, it's Eva Nykänen, who's the Chief Specialist and Head of Team at the Institute of Health and Welfare in Finland. So I know you had some connection challenges, Eva, but I hope you can hear us, and over to you.
Yes, thank you very much. I hope that you can hear me. I thank you for this opportunity to bring the Finnish perspective to this webinar, and also thank the previous speakers for very insightful presentations. And yes, it is true, I have had some connection problems. So if I just happen to freeze, or if you freeze, then I just need to leave the meeting and come again. But I hope that this will not happen during my presentation. So let's go to this. So it's about the case of Finland in prioritization. So thank you for the first slide. As a lawyer by my education, I start with the Finnish constitution because Finland is in this respect one of the rare countries where social rights are granted as constitutional rights in the constitution. So in section 19 of the Finnish constitution, there is a right to adequate services and an obligation to promote health. So this sort of a right to health section in the constitution has two sides. First, there is the public authorities shall guarantee to everyone, as provided by Act, adequate social health services, and then they also have an obligation, constitutional obligation, to promote health of the population. So there is quite a strong sort of a mandate for the state to be active in this field. However, so far the emphasis on legislation and policy measures has been primarily on the right to adequate services. So this is where the focus and very much resources have been invested. But of course, there are certain measures which are implementing the second half of this constitutional guarantee. So for instance, we have the alcohol monopoly, which can be, or which is sort of, for instance, identified by the Constitutional Law Committee as one of the methods with which this promotion of health is implemented. And there are a number of different governmental programs and resolutions which seek to stress the emphasis on the promotion of health. There is also an advisory board on public health, which has the task of bringing health promotion as a part of the overall policies and strategies. Can I get the next slide, please? But now there is some new tools for promotion of health, and which I'm going to discuss here today. So so we are in a way facing a new era in Finland in this respect, and it's quite interesting to see where this will take us. So as you probably know, in the beginning of this year, we had a major reform of social and health services. So far, the services have been organized by the municipalities, and there are approximately 300 municipalities in Finland. But now, starting the beginning of this year, the responsibility for organizing the services was shifted to the well-being service counties and the city of Helsinki. So now there are 22 organizers plus the city of Helsinki. So we are still very much looking how the organization will change the structures. We don't have too much experience about that, of course, because the municipalities have just started to perform their functions and to make decisions about the service structures and so on and so forth. But in any case, we are in the beginning of a new era. One of the aims of this major reform was to enhance prevention and to strengthen the primary services, and also in a way to support these aims, to also strengthen this state control of the social and healthcare system. The new entities, the new counties it constitutes a new level of public administration, so they are self-governing entities, but they don't have a right to collect taxes. Can I get the next slide, please? And this is, in fact, one of the kind of the tools for achieving, or we can see as the tools for achieving the aims that were placed on the reform. So first of all, because the state is responsible for funding the counties, the state has a power to also participate in defining the aims of the counties. So there are, well, they are self-governing, so the state cannot decide on their behalf, but still the state has a kind of a strong powers to seek to guide the counties. So there are negotiation processes between the state and the well-being service counties. And in these processes, it's possible to set aims, and of course, enhancing prevention can be defined as one of the strategic aims. And this is, of course, something what we hope that will happen, taking into account that this was one of the aims of the whole reform. But maybe even more importantly, this allocation, or this the system for allocating resources to the counties offers another other tool for promoting or enhancing promotion and prevention. Because as I said, the state will, can I get back maybe to the previous one? Yes, the state is funding the counties, and the managing of the funding will give a state some powers to seek to guide the counties. So now can I get the next one? Because in the funding system, there is one part, coefficient for health and welfare promotion, which is based on the activities of the counties in the field of health promotion and prevention. This is not a big sum of money. It's just when it comes to the counties, it's like 1% of the total funding. And this coefficient is also applied in the municipalities, which continue to exist, even though they are not arranging health and social services, but they are still running like a primary schooling and other public services, and they get some state funding for that. So both the municipalities and the well-being service counties will get part of their funding in this kind of a form of health and coefficient for health and well-being promotion. And how this happens, we don't know yet exactly. When it comes to municipalities, this new funding system will be activated this year. So already this year, they will get some of their approximately 1 million euros shared to the municipalities based on this, this new coefficient. And when it comes to well-being service counties, this new system will become activated in 26, because of course we first need to give to the new entities a time to organize their activities and set their strategic aims, and then start implementing their powers, and only then we can assess whether they have been successful in setting the aims and reaching them. So this is why we only start using this part of the financing after some years. Can I get the next slide, please? Because this is and showing the total funding. If we look at the wellbeing service counties, the small blue, light blue share is this new coefficient, while the other parts of the funding will be allocated on other grounds, primarily on needs based, so that the needs will be assessed, and then the primary part of the funding will be allocated on that basis. But still there is this one sort of incentive, the purpose of which is to make the counties and also the municipalities to take efficient action in this field. If I can get the next slide, please. This is a little bit complicated picture, but it is showing how the coefficient is sort of constituted in case of municipalities. There are two parts. 50% will be based on process indicators and approximately 50% on outcome indicators. And the process indicators describe like measures which are taken. For instance, whether there is annual reporting on health promotion, whether there are like annual health checks, and whether the municipalities are running, for instance, arranging sport activities in the field. So it's like more what they are doing. And then the outcome indicators are then based on whether what the municipalities are doing actually have effect. So here we look, for instance, the share of overweight youngsters who are at the grades of 8th and 9th grade at school, perceived health. And this is also this is based on kind of a survey which is done in the 8th and 9th grade at school, and this is the information is sort of indicating how these young people perceive their own health, and what is the percentage of youngsters who perceive their health as a weak or average. Can I go to the next slide? And this as it comes to municipalities, as I said, it has started this year, and now this last picture that I have here, last slide, it is describing the well-being service counties, how that is that coefficient is sort of constituted. So again, here we have process indicators and outcome indicators. When it comes to process indicators, we look, for instance, whether the counties are arranging health examinations, whether there are social workers working in schools and student welfare services, children vaccination coverage, and other such process indicators, which of course we get from registers, whether these things are being done or to what extent these things are being done. And then there are outcome indicators, for instance, a percentage of people over 64 years who have a hip fracture, so have been hospitalized because of that, and also number of cases of injuries and poisonings treated in the healthcare. And this information we are either collecting directly from the registers or then surveys, because, for instance, THL is making some surveys like every second year, every year for different age groups and different sections of population, and we are getting this indicator information through that. I stop my presentation here and remain at your disposal to answer any questions that you have.
Yeah, great. Thank you very much, Eva. We already have several questions for you. And
I hope that I have answers, because the system is so new that.
Okay. I will try to state them, but for those of you that enter questions into the chat, please let me know if you prefer to present them yourselves, which is often better than my inferior restatement. But let me try one now from Martina, which is about the evidence. And she asked, in order to support our prevention interventions and the case for prevention, could we get the more or harder evidence if we did some studies combining prevention and curative interventions and showing that the combined intervention would be better in terms of outcomes than curative interventions alone?
Sorry, was that a question to me?
I think the question, Martina, let me know, of course, if you would like to elaborate. But the question is, I think, simply, could we do more in terms of looking at the combined outcomes of preventive and curative services or interventions than looking at each in separate?
Yeah, well, definitely. And if I presume that this question is also for the other speakers, but when it comes, for instance, to the indicators that we are using in this sort of a funding system, they seek to, or we have tried to choose indicators which are not just telling about one sporadic thing, but rather indicators that are describing a broader sort of issues or broader sort of directions of development. So definitely, I think that there is a sense in trying to have a kind of a more complete picture and use indicators that describe not just one thing, but more general direction of the development.
Yeah, great, thanks. And Martina clarifies that her question is very much to all the panelists, and I guess all of us. I mean, Anders also talked to the at least perceived often inferiority or more softness of evidence for preventive services. So maybe that's something we can come back to in the general discussion. But Katarina, I have one question to you, Eva, as well as others. What role does the concept of co-benefits play in all the three public health systems? For example, in regards to climate change and health, are the benefits of, for example, introducing plant-based meals in community facilities, such as schools or workplaces for climate and health, factor into the funding streams? And also the impact evaluation of interventions? And if yes, where could I find more information on that?
Well, if I start, I presume that this was also for all of us, but unfortunately, I have to say that maybe in Finland we are not very far in this field yet. So there have been some research projects on sort of trying to incorporate this kind of environmental issues in this health promotion thinking, but so far we haven't, for instance, managed to somehow bring them into the indicators. But this is definitely something that we still have to work on.
Great, thank you. And then also a question, of course, we can revisit later, the issue of co-benefits and the problem in some ways. I mean, it's good, but it's also could be challenging that the benefits occur in more than one sector. Elena comments that this was an extremely interesting approach, reminds a bit of Programa Sumar in Argentina, recognizing the role of local government and the need to go beyond the health sector. And then a lot of questions and comments. One from Björn here at this institute. What type of interventions can be funded under the health and well-being promotion? Are these interventions in the health system, or can it also be activities as improving cycling paths and payments to promote physical activity?
Was that a question for me regarding the Finnish? Yes, I think that part of the funding of the municipalities, one indicator is kind of activeness in establishing sport possibilities, arranging sport possibilities for people. So it is a little bit, in a way, inside there. And then another, especially when it concerns the new counties, the indicators, they have been built in a way that they are quite extensive, so that they also sort of cover this kind of activation activities or sort of promotion of sport and sport possibilities. So, for instance, overweight is in a way behind that is also this kind of issue. So they are not so narrow, but in a way, this kind of thinking is behind them.
Thank you. No, thank you, Eva. So I think we can move on and then save the questions and comments for our general discussion, because as you say, several are really questions for all of us. So before we enter thank you again, Eva. Before we enter the general discussion, we have invited the RIVM to also provide some comments and experiences from the Netherlands. I will start with inviting Marit Wolp, who's the Director of Public Health and Health Services at RIVM, and I think she have with her Sten Selle, who's advisor for international affairs for public health, and please, we look forward to hear from the Netherlands.
Thank you. Here I also had some audio difficulties, so I'm trying to keep up with hearing all the very interesting presentations. Well, maybe it's good to just point out what works in the Netherlands. We have experience that is very important in the political system to use the health protection angle. So we now have a more or less liberal government that's quite against patronizing or patronizing issues like ban smoking quite easily. So what we do is to have the prevention narrative as an approach, which is less perceived as patronizing. So smoking ban for minors under 18, banning alcohol or other vaping, so those kind of things, that usually works quite well. The problem is with adults. So then trying to get legislation for banning smoking or making it more difficult to buy cigarettes is usually countered by the liberal parties in our government. Another thing I think is very important to point out, that our healthcare system and insurance schemes are mostly for the cure part of healthcare. And it's very difficult to add the more prevention and lifestyle interventions within the insurance schemes. We do, though, have one success, which is called the combined lifestyle intervention. It's insured care for patients with obesity, and they get guidance in nutrition, exercise, and behavior. And the goal is to create a healthier lifestyle. And the first studies we have from this intervention is that it's proven effective. And that's also like a start for pointing out that prevention can be effective and should be also included in our insurance schemes. Anders, I think your system in Sweden is quite comparable to our system. Although we don't have the regional level. And I was wondering, maybe that's a question for later, or maybe you can answer it now, whether you are, maybe it could cause, if there are a lot of local and regional differences in prior, that there can be differences in getting people get the help they need. So I was wondering if you have any signs or signals that that's happening, like differences between rural areas and the more urban areas, and how Sweden is handling that. Thank you.
Thank you, Marit. Would you like, it was a direct question to Sweden, but Sten, would you like to add something from the RVM side, or?
Maybe for background, we do have a national prevention agreement in the Netherlands. So it's kind of a dance between all parties in the Netherlands that do something about health, and also the industry. So that's an interesting dance, I would say. But for now, there are 3 priority themes in this agreement. So we have smoking, alcohol, and obesity, which are the top 3 determinants of unhealthy lifestyle. And more than 70 national parties signed this agreement, including the industry. So what Marit also told, that important in the Dutch context, is that the municipalities are responsible for most of the prevention activities. That's why we also have to work with local prevention agreements. So in each municipality, they have their own agreement on with those parties that work on different issues within health. So the priorities within each municipality can be different based on what the energy is in that municipality. That's just something I wanted to add.
Thank you very much. And Anders, would you, on the way over to the last panelist, would you like to respond to Marit's question?
Yeah, I mean, it's a very good question, because how do you handle equity in a system where you have so many different responsible actors? We have tried in Sweden to handle it in different ways. I mean, one way is legally, the communities and the regions are obliged to provide similar services. So there's really, talking about the legal background, there is a legal background to that. They are not really allowed to differ ever so. So that's one side of it. The other side of it is that we, together with the communities and regions, every 3 or 4 years, publish what's called open comparisons in different areas, among them also public health, to show that there are certain differences. But differences are not by nature necessarily bad. I mean, the Swedish system also builds very much on that each community, each region really can focus its resources on where it's most needed in that region. And that's why we also publish quite a lot of data on the difference between the regions when it comes to, for example, alcohol problems and so on, so that they also can themselves sort of design where they want to put the resources according to what are the major challenges in their specific area. Because they tend to differ quite a lot between the different regions in Sweden. So to a certain extent, I think there is also strength in having a system that can be flexible and adapt to the local challenges.
Thank you very much, Anders. Another challenge for many of us, or not only a challenge, but a factor to acknowledge and be responsive to. I think we might have the 4th pre-planned panelists now on board. We had some connection challenges, so that's why I've been a bit liberal on time. But I think Martin Dietrich, are you online now?
Yeah, thank you very much. And sorry for being late and having connection problems, but I'm on board now.
So great. Very much welcome also to you, Martin. And just to introduce you short but more properly, so you are the director of the Federal Center for Health Education in Germany, and we're very much looking forward to hear about your experiences and insights.
Thank you very much. After I've heard so many very interesting comments on lifting prevention from the other speakers. I actually asked myself if there could be any additional insight that I can provide from Germany, and I think I can, but from an implementation perspective. So I just want to share my screen and want to ask you if you're able to see my presentation.
Yes, but we also see your next. Now it's perfect.
All right. Thank you very much. So besides my function as the acting director of the Federal Center for Health Education in Germany, I'm also the president from EuroHealthNet in Belgium. And I just allowed to cite the email message and what we think, or what I think should be very interesting for the discussion, how we can lift prevention. And I just wanted to highlight a few things that I have recognized in this email conversation from Lisa, and it's the prioritization of resources for preventive interventions. That is what I will look closer at. And so the question is treatment being prioritized over preventive interventions. How can work against this perhaps to get more prioritization to the preventive interventions? And I will give you a perspective primarily from health promotion. So in the end, what my view on the subject is, a view from a German health education perspective. And I want to go into 4 steps into the issue. Want firstly discuss the relevance, and I will then want to go to questions of effectiveness. And then I want to provide an idea how to use models in preventive interventions, and actually closing with the questions of setting the right incentives in health systems or societal systems to lift prevention. And perhaps I can give some ideas about how the health financing system in Germany might be regarded as not so prevention friendly. So the health promotion, disease prevention implementation of interventions by a federal agency and departmental research facility, like the PZGA, the Federal Center of Health Education is based on 4 aspects. Of course, the first thing is the technical assessment of what is actually needed from a health perspective or from an illness perspective. This is information provided usually by health monitoring. There is also a political prioritization of prevention activities. And we have to regard also legal feasibilities. As you know, Germany is also federal organized, and the federal state has not so many competencies with respect to prevention compared to the state or the Länder level or the municipality level. And there also are to be respected administrative laws and budgetary frameworks, what means that money has to be provided to realize prevention interventions. The relevance of the health promotion and disease prevention as a multifaceted entity, the setting the scene, depends on a few points that are listed here. Of course, it's the scope of a medical problem, and these are epidemiological criteria, incidence and prevalence, how many people are affected by an issue. The scale, the size of disease burden has benefits, so-called the severity of condition, is there any possible health gain? The cost of illness is to be taken into account with respect to medical services or with respect to all illness costs. What I will be more talking about is the effectiveness. We do need causal evidence with the interventions, effect size, and robustness and scalability of prevention interventions. These are very important by lifting the priority of preventions, in my view. And we also look at feasibility, capacity, and trends. So what has been mentioned by the speakers before, is one of the key assumptions I have made for this presentation. It is that the awareness that health promotion, disease prevention is an effort of many actors and a permanent challenge, not only in pandemics, but also in normal times. And within this realm, and we have heard it from the speakers before, there is some effort to be made to set the agenda in health systems transformation efforts. And I just want to give you an idea about prioritization settings or priority settings, that this is a more an evidence-informed deliberative process. So this is from Baltussen and colleagues who have set a model of setting priorities and how this process should be designed. And one of the features of this model, I'm not sure if this has been enacted internationally or if it is just a hypothetical model, but the thing that has been argued is that the process needs to be transparent and the process needs to take into account the different views of the stakeholders to get the prioritization in the prevention section accepted by all the stakeholders. So from a German perspective and the perspective of the Federal Center for Health Education, we have stumbled about some questions that always are connected to the question how to prioritize prevention. And these are the following. Prioritization and resources are also connected to the questions of using scarce resources, and the efficient use of scarce resources, usually a domain of economics and in health systems, of course, of health economics, as has been mentioned before. From an economic perspective, cost effectiveness can be an appropriate approach to support the prioritization and health service interventions. But cost effectiveness analysis is basically a two-stage process that starts with the analysis of effectiveness before cost analysis make any sense. So for prioritizing health promotion and disease prevention higher, the effectiveness of health promotion and disease prevention interventions has to be in the focus of any efforts. So prioritization criteria and effectiveness means that we need valid causal relationships in health promotion and disease preventions. And we have to ask the questions how we can support these causal evidence. So lifting the prevention section within health systems is closely related, in my view, with our success in providing causal evidence for preventive interventions. So with respect to how we can proceed in this direction, you have mentioned soft evidence before. I think the use of intervention models should be one way in which we can show how interventions really work. And as we have mentioned before, prevention activities are an effort of many stakeholders within a country. And we have to use these different influences on outcome variables and outcome criteria. And I think we need models that take this into account to indicate what preventive interventions actually can do to add to the health status of a country. And we also need health monitoring that provides data sensitive to health promotion, disease prevention, intervention path. And we have to collect data and put them together from different sources, behavioral data, health literacy, socioeconomic indicators, and so on. And we need data integration and a free data access so that actors can actually use this data to derive implementation models for this. What I mean with modeling or with prevention models is what I will show you in the next slide. It is a hypothetical model, but it makes clear what preventive interventions should be looked at from a model perspective. So this is a picture of how interventions for health promotion may work. And we do have some kind of evidence for activities within these frameworks of health promotion and disease prevention activities. And intervention partners have to be laid into these total model with respect to what activities can be undertaken to support and impact what is here indicated by YO. So the gray circle in the middle may be an organizational responsiveness with respect to what activities can be undertaken. So these are then intervention variables that can work through the model to make an impact in the end. The thing I want to highlight with this graphic is that we need total models of preventive intervention so that we can identify on which steps we can actually provide evidence for causal relationships. Because in the end, if we want to do something like cost effectiveness analysis, the core criteria that we have to provide is providing evidence for causal relationships to say on what hard outcome indicators we actually can provide the evidence that something really works. So the last point I want just to mention is that we have to set incentives within the health systems, and we have to set incentives on two levels. On the health system levels, basically health insurance systems and healthcare financing has a major role in promoting health promotion. And we have some health illness dilemma because in Germany, for example, we have a health financing scheme that allows health insurances to receive more money for more illness in their risk portfolio. And there is basically a reasonable way to think about this so that illness is not something, or high risks are not something that health insurances should avoid, but should take into their portfolio. But by the way, if the illness is taken into consideration, the avoidance of illness is not be incentivized by this scheme. And this is especially because the risk-adjusted reimbursement schemes we have in the German healthcare financing system. So we have low health system incentives for health promotion and disease prevention so that the activities are not directed into these fields of action. On an organizational level, we have a disease-based health service providers revenue logic. So what is paid for is basically for medical services, what is therapy or diagnosis. And we do not have hard outcome indicators for health-related reimbursement schemes for health services. And this is what the incentives are actually in Germany, what makes prevention a little bit more difficult. So to come to the end, I think the relevance of prevention and health promotion is a result of a societal discourse that has to be led transparently. We have to use effectiveness information about health promotion, disease prevention interventions, what can be supported by using models in which these intervention paths are modeled, and we can provide information about causal relationships and causal evidence. And we have to think about setting the right incentive that these activities are really undertaken in the health system. So thank you very much for your attention. I hope I have not overemphasized my time. This is a German perspective from the health promotion view. Thank you very much.
Thank you very much, Dr. Dietrich, and very structured and speaks to several, elaborates several of the points we have discussed before you, I think you joined. So we had taken some questions along the way and have just some few minutes left for additional questions. But before maybe I pick some of the questions in the Q&A box. Can I ask anyone to raise their hands that would like to present their question themselves and or have some very rapid experience from their country that supplements what we've heard or reinforces what we heard so far. Just some few seconds to see if anyone would like to join orally as well. If not, we will pick some questions here on the Q&A. Because as several of you mentioned, several of the questions here, of course, goes to all of you really. And one of them was really about, and I think all of you have touched on it, soft versus hard science, I think, or evidence. I think that sometimes can be a misnomer or lead us astray. But do any of the panelists can comment on that? What can we really do to improve on the primary evidence that we have for these interventions? Martin, please.
Yes, I think we should make use of rigorous effectiveness evaluation methods, and we should do some more efforts also with respect to funding research in the field of quasi-experimental designs in which we can prove effects. Perhaps you know that my background is health economics and empirical research, and I know that there are methods and that there are instruments by which we can use observational data that are not as strong as clinical trials. I know that, but we have instruments with which we can argue for causal effects that can be proven in observational data. And I think if we could put more emphasis on research in this area, so that efforts are undertaken to make really strong assessments of causal relationships, then there are ways to do so. But we have to rise and make some kind of agenda setting in the research field for health promotion, disease prevention, so that these activities, field experiments, and so on, are really undertaken. And I think if we would spend so much money into health promotion, disease prevention research activities as we do it in clinical research, we could do a lot of improvements by providing causal evidence. That's my view.
Thank you very much. Anders.
Thank you. Yeah, no, I agree to a certain extent. Yes, there are definitely methods, and we need to go beyond this to be always grading the case control, the control studies as high, and try to get an understanding that observational studies can be just as important and maybe sometimes even more important, because we know that a lot of things happens when we take preventive measures out into the big populations. The results are often quite different and so on. So I think really, in my view, observational studies are sometimes even better than the control studies in a very controlled population. So I think there's definitely a lot behind that, and we need to promote that better, get the different magazines and researchers to understand that there is a world beyond the control studies that we do in the hospital settings.
Thank you, Anders. Sten, please.
Thanks. I'm maybe a little bit more negative about doing more research because just of these clinical trials, as was Anders saying, what you see is that you have to track a lot of people for a long time, and all the factors, social factors, social determinants, for example, they will change after a while. So you need big groups and long and big studies, and all the variables will change after a while. So we need more observational studies, or maybe what I believe is more effective is just law enforcement and regulation. That's, in my view, that's the most effective. But you need a lot of support from the government, of course, and the public.
Thank you very much, Dan. And I will share in a moment why I privileged the question of evidence. It was a bit selfish. But I think we are, and I will explain why, but I think we are not able to address all the questions at this point in time. We have 3 minutes left, and I thought I would just briefly not try to summarize this, but just recap for us some of the keywords, at least the way I heard it. And just to say, we will share both the streaming of this webinar. We will share a short summary on the website, and also the slides to the extent that the panelists accept. And please, and it will also be shared in the newsletter called the Insider, which I think most of you, or I hope most of you, subscribe to. So a more thorough summary will be shared. But just to summarize a bit, I think we have covered a lot of the possible levers or measures and instruments to counteract, so to speak, the drivers that I mentioned in the beginning. We have talked quite a bit about how to best assess this kind of broad interventions, especially how to set up systems to better assess. And we haven't really compared it to health technology assessment on the clinical side, but I think there are some interesting analogies there. We also discussed some of the more, micro questions around how to best assess interventions, and the related question about intersectoral collaboration, both on the assessment phase and the implementation phase. And of course, on the assessments phase in particular, we have this question of co-benefits that I think one of the, or several have touched on, and we didn't get time to go into in very much detail. Then we have discussed the issue of levels and how the national level and national institutions best can support municipalities and the local level that obviously will not have the capacity to assess these kind of interventions very thoroughly. But at the same time, we have to contextualize properly when we make recommendations or assessments at the national level to support the local level. Indicators as one key lever or measure that can be used to prioritize and better prioritize prevention, including as part of incentive systems, maybe most clearly presented from Finland, clearly connected to financing. We have touched on, but we didn't really get time to go more into the Dutch experiences with these agreements, where I hear also industry is part. And then finally, we discussed quite a bit on the potential for better primary evidence or primary studies on public health interventions. And the reason why I privileged, so to speak, that question in the chat is that a follow-up webinar from this one will try to go directly into that question, following up from this broader discussion that we had today, and focus quite directly on what can we do better in terms of rigorous studies for non-pharmaceutical interventions, or what is now called public health and social measures, especially in the infectious disease area. But of course, if we manage it there, we should manage it also with other broad-based interventions. And I think several of you mentioned quasi-experimental designs, but in that webinar, we will also discuss the potential for randomized controlled trials. And as we already heard today, is quite different views on the potential and feasibility of this kind of designs in this area. So I think that will be a really interesting follow-up of this meeting, and I hope you all will join us for that webinar, which will be in February or March. So then we are on time. Thank you very much to the Secretariat that have helped organize this, Anders for coming up with the idea, to all the panelists, and of course to all of you that participated and so actively that we couldn't even get through all the question this time. So thank you again, and hope to see you in a later webinar.